Hi, I'm Oliver van Oekelen. I'm a PhD student at the Icahn School of Medicine at Mount Sinai in New York. Today I want to give an update of the data that we've collected from myeloma patients after receiving a SARS-CoV-2 vaccination. Previously we had published studies highlighting the fact that after 2 doses of mRNA vaccine, either Pfizer or Moderna, we saw that there was a significant fraction of the patients, about 15 or 16%, that were unable to develop any anti-spike specific or spike-specific IgG response, so a humoral or antibody response to the vaccine. And we've complemented that with studies in about 50 myeloma patients now showing that this is not only true for antibody responses, but also for T-cell responses, and that patients, specifically those that don't have any antibody response, are also at high risk of not having T-cell responses. And this, to us, suggested that they might be at a higher vulnerability for COVID-19 infection. Importantly, we saw some important association with the treatment that patients are receiving, because obviously the question becomes whether or not it's the disease itself that is causing some immune suppression, or whether it is the chemotherapy or other treatment regimens that contribute to this lack of response. And we saw that patients that are being treated with a CD38 monoclonal antibody treatment regimen, or patients that were on a BCMA bispecific antibody treatment, that they were at the highest risk of not having antibody responses or T-cell responses to the vaccination. And as time goes by, now we are happy here at ASH to give an update of the data, and we have collected now longitudinal data up to 12 months after vaccination, and that clearly shows that not only is there a higher risk of not having an antibody response, but also the responses appear to be much more transient in the patients that are being treated continuously with BCMA bispecific or anti-CD38 monoclonal antibody. Importantly, now, obviously we have collected data from myeloma patients that have received the 3rd shot, and people have been speaking about 4th shot as well. And after the 3rd shot, we've seen that those patients that had no antibodies after 2 shots, about 80 to 90% of them actually is able to finally mount detectable antibody levels at decent levels after receiving their 3rd vaccination. So a very important takeaway, I think, is that we should try to get as many patients as soon as possible to receive their 3rd dose of the vaccine, because that is able to elicit an immune response in a large fraction of those patients that were unable to do so previously. The other patients that have detectable antibodies also respond very favorably to the 3rd dose, where we saw the antibody level increase more than tenfold on average in the patient cohort. So again, the bottom line here is that it's very important, I think, at this point to get as many myeloma patients as possible to receive their 3rd shot as soon as possible, given specifically the advent of new variants and things like that. An important question is how we should counsel patients that are unable to develop antibodies or have unmeasurable levels of antibodies. And recently there's been the approval of a prophylactic, I think, subcutaneous antibody to actually help protect patients and make sure that they don't develop COVID-19. I think right now it's important to study and see if that actually protects patients. I don't know. I don't think they've looked specifically at myeloma patients, but I think we should acknowledge the fact that patients are at a very high risk, and that for some of those that are immunocompromised and that we've been treating with IVIG in the past, this might be a solution to protect them, especially when we have data to suggest that they don't have any antibody levels at all.